It is a huge honor today to be interviewing a very distinguished endodontist, Rodrigo Cunha. How are you doing today?
I'm doing great. Thank you for having me and giving me this opportunity to discuss with you guys.
Oh, the honor is all mine. You're actually very good friends with a gentleman we podcasted earlier, Ken Sirota, who's also a Canadian. You're a Canadian in Manitoba. And Ken Sirota, I mean, I just love that guy. I mean, he can quote endodontic literature like some preacher quoting the Bible or the Torah or the Quran. I mean, he's just an amazing wealth of information, and he has told me so many great things about you and how smart you are. And but my first question before we get into root canals is, my God, you were born in paradise. You were born in Brazil, and now you moved up to Antarctica in Canada. How does one go from Brazil to Canada?
Well, we like to say that we come for the weather, right?
No, you did not come for the weather.
No, it is. I graduated in São Paulo in 1994, where I did my specialty program. I started teaching there in 1996. And after 17 years of private practice, I decided to move to the North Pole in order to engage on an academic career here as well. So I applied for a position in Winnipeg, Manitoba, and funny thing is, I didn't even know what Winnipeg, Manitoba was. But I had been in Vancouver in 2007, and I remember that when I applied for the position, my wife asked me, "Listen, what's Winnipeg, Manitoba?" I said, "Don't worry, I've been in Vancouver. It shouldn't be that different." It's quite different. It is cold. It is super cold, but it's been an amazing adventure, if you want to put it that way. I've been having the opportunity to meet amazing guys, amazing endodontists, learn with them, and I will for sure quote Ken Sirota as one of them. His passion for endodontics is just
unmatched.
Yeah, and he actually, we discussed a couple of times about endo, and he was the one that said, "Listen, you should do this and share your knowledge and whatever you've been doing clinically," and that's what I'm here for.
So your wife, how long have you lived there in Manitoba with your wife?
We've been here. This is our 5th year.
And she stayed with you the whole time. She didn't leave you and go back to Brazil?
It's good because it's so cold she doesn't leave the house. So she can't leave.
She can't go home because she can't leave the house.
No.
So basically, when I got out of school, it was all hand instruments. And I have to tell you the truth, the first 5 years I practiced, I always had a blister on my thumb and my finger from just doing this filing motion with files. And, you know, in my practice, I'm in Phoenix, Arizona. I'm not in a rich suburb or anything. And I did a molar or two every single day. And now, and then it just slowly but surely, it just turned all Nitai, rotary instrument. And I got to tell you, before you get into this, I know you like a file from a TRUShape, which is Tulsa Dental Products. And I want to tell these young kids, Tulsa Dental Product, the name Tulsa comes from Tulsa, Oklahoma, because that's where the founder, Ben Johnson, started the company. And I got to tell you my Ben Johnson story. In fact, do you still talk to him?
Well, I know of him. We've met, but we never had a huge conversation, but I know of him. Yes.
Yeah. So anyway, so he started his company, Tulsa Dental Products in Tulsa, Oklahoma. And I was a kid. I was 24 years old. It was 1987, and I didn't understand some of the stuff. So I, called the operator back. They used to have operators back then, and got his number, called his endodontic practice, and I'm talking to him, and he says to me, he goes, well, I wish I could show you, but you're in Phoenix, nice. And he goes, Southwest Airlines, they fly straight from Phoenix. So you got to come down here and spend the day. And I said, I don't think I could learn it today. It'd probably take 2 days, and I'd buy the plane ticket, but I have the money for a hotel. And he goes, well, then stay at my house. The guy was just a saint. So here's this 24-year-old idiot kid getting on an airplane, flying to Tulsa. He picks me up in his car, and he's showing me how he rolled the gutta percha and how he made the original. Just a saint of a man. And I think he's got to be the coolest endodontist in the world. In fact, that was so long ago. I don't even think he was an endodontist. Back then, you could just say, I'm only doing endo, so I was practice limited endo.
Yeah,
So
practice limited to endo.
yeah. So he didn't even. I don't think he went to endodontic school. I believe that's what he said. And I know a bunch of other guys in small towns where there will be like five guys in a town, and nobody likes to do endo, and one of the guys loves it, and but they're not going to refer him to endo because they'll do all the other work. So one of the five guys in the small town will just say, you know what? I'll tell you what. I'll have practice limited endo. I'll only do the endo. I'll get rid of my hygienist. I won't do crowns, fillings, whatever. And there's a lot of people practice limited to endo that never went to endo school. But anyway, so enough of that. What would you, you got about 7,000 dentists listening to you right now. Probably almost all of them are general dentists. I don't think I have a big specialty following. What would you like to share in this hour? What do you think could make these people listening to you today do better endo?
Well, Howard, that's a great point. This is what happens today. We hear a lot the sentence, look, endodontics is a dying profession. Why are you still doing endo? Today we have implants. Why are you wasting your time trying to save something that's not going to last? And I think that I went from a really huge frustration to starting to try to understand why they're saying this, trying to be realistic and seeing that, yes, a lot of the teeth that we are doing are failing. And the other thing I try to do is understand why it's failing. So just to get started, I just want to let you know that I think that we can do a better job, and that's what we're going to talk about. But I also want to let you know that in the university setting and in my private practice, I see a lot of implants failing. So the question is, are implants really predictable as they sell them? No, they're not. They also fail. So we have to acknowledge that implants fails, and we have literature. We have plenty of pieces of literature out there showing that the success rate of implants is not as high as what's being quoted there. Actually, we have a huge network group that published a paper in the Journal American Dental Association in July 2014, where they stated the success rate of implants in a general practice setting is not as high as in the university setting or the specialist setting as it's quoted out there. So the question that comes is, okay, so what should we do? What should we do to increase the success rate in endo or to decrease the failure? I think the first thing we have to do is to try to understand why root canal treatment fails. So if we go back and we look at the causes, the main causes are, one, missing canals. Missing canals is a huge cause for endodontic failure. What have we as endodontists been doing in order to avoid this? Well, today we have dental operating microscope. Today we have cone beam computer tomography. We have our surgical loops. So we have enough tools to avoid missing canals. What is the other cause? Well, persistent new infections. Yes, that's also cause for failures. What have we been doing? We have new irrigants out there. We have new technologies. We have different irrigation protocol. We have sonic activation, ultrasonic activation, all in order to try to fight those bacteria and other bugs in order to give us a higher success rate. The other huge cause of endodontic failure is vertical root fracture. And I ask you, Howard, what have we been doing as clinicians in order to avoid vertical root fracture? If we really put our minds set just to think a little bit, you're going to see that we haven't been doing a lot. The way endo has been taught for the last 30 years and the way they've been teaching how to do root canals, it's all about remove what you have in front of you. I want to reach the apex no matter what. I want that straight line access. So again, going back to the literature, and I can quote Gualabivala's group in 2010 that published a paper in the International Endodontic Journal. They quoted that preserving tooth structure is extremely important. Excessive root canal preparation is one of the causes of vertical root fracture. So I have no doubt that going small today is the way to go. So I don't know if I agree 100% with the terminology minimally invasive endodontics, but I like the terminology dentin preservation. So it's not only about doing the root canal, it's about doing your root canal and be sure that you leave enough tooth structure behind so someone can restore that tooth and we can give that tooth the longevity that we want. Because, Howard, there are two important aspects here. We as endodontists, we like to look a lot at the outcome. Outcome is the success of my root canal. So was my root canal successful? Yes, it was. Did the lesion heal? Yes, it did. That's great. Okay, how long is the tooth going to stay in the mouth? How long is that tooth going to stay stable in the mouth? The patient is going to stay, the patient can chew, the patient can carry on with his life, and the tooth is going to stay there. So, Howard, I think we're at the point where we should only be looking at the outcome. We also should be looking at longevity. We should be looking at how much time I can give this tooth in the mouth. And I'm always looking at the maximum possible. I want to keep the tooth there forever. So keeping tooth structure behind, leaving tooth structure behind is paramount for sure. We already have studies coming from, and I can quote Friedman's group from Toronto, where they actually just published a paper in the JOE in 2014 comparing conservative endodontic access and traditional endodontic access. Maybe we are removing too much. Maybe that straight line access that we've always been quoting and teaching doesn't have to be that straight anymore. Because, Howard, if you think with me, straight line access, the idea of a straight line access was created when our files were stainless steel files. Our files were so stiff that we could not actually negotiate a curvature. However, 30 years later or 40 years later, we have completely new tools. Our instruments are made of nickel titanium, extremely flexible, and we're still advocating a straight line access. So we are using an old concept, however, our tools are completely different. We can actually do the same, removing less tooth structure, leaving more dentin behind in order to give that tooth longevity. So, where does the TRUShape concept come in? When I saw the TRUShape concept, I really saw something different. You know, the same as I do, we have more than 60 NiTi system, rotary reciprocating systems in the market. There's too many, and each one of them promising something different. But when we look at them, Howard, they're pretty the same. We are always switching files, but you know what? You're switching something for something that's very similar. When I looked at the design of the TRUShape files, and I went to a meeting in San Francisco with Dr. Ove Peters, where he actually introduced those files and showed how to use them, the concept, the idea, all the idea of dentin preservation. Don't remove too much. Let's try to keep it there in order to have something to restore later. I really said, wow, this is genius, and I think that now I found something different. So I started using, actually now, October, I think it has been a year since I've been using these file systems. I like the design. It's an S-shaped file. That S-shaped file is interesting because even though the file has a specific diameter, because of that S shape, you can still touch the canal walls. So even though the file might be a little bit small, because of its shape, you're still touching the canal walls even when the canal gets larger. So we're still waiting for more literature, but what we've been seeing out there is that you can actually have a conservative preparation but still touch the canal walls in a way where you can leave less bacteria behind. This system basically consists of 4 different files. So we have the 2006, 2506, 3006, and 4006, and they have a variable taper. The nice thing is it doesn't matter which one you use, if it's from the 20 all the way to the 40, all the way at the end of the file, at the D16, 17, your preparation is conservative. You're preparing in a way that you're preserving tooth structure at the coronal portion. If you need to modify the orifice, they have this instrument. It's created with the blue technology. It is a vortex blue technology where it's called an orifice modifier. So you can modify the orifice. And look how interesting it is. It's not about opening the orifice shaper, orifice opener. No, it's orifice modifier. We don't want to remove too much. We want to just modify so my file can go in easier. What else can I add to this file?
Well, it's amazing. Back in the day, dentists would start with a big old football Gates Glidden and just blow out those orifices. And then when Nighties came out, they had 0.02 taper, 0.04, 0.06. And these tapers were so huge because, like I say, the main goal is a straight line access, get to the bottom. And they've just blown out this whole thing. And that's what you're saying, that you've removed so much dentin structure that's setting these up for root fractures.
I agree with you. Howard, just for you to have an idea, we're not even using Gates Glidden that more in the way we used to before. As you know, I am a full-time professor at the University of Manitoba, and even to my students in undergrad, I try to teach them how dangerous Gates Glidden is. Sergio Cutler has a nice research study published in the Journal of American Dental Association where he showed the remaining dentin thickness that you leave behind after you use Gates Glidden can really put in jeopardy the longevity of that tooth. For those that find it hard to just quit the Gates Glidden in one step, and you know what, I still use them, I don't know, I'm so used to them, what I usually advise them to do is use your Gates Glidden number 2, 3, not more than that. I think we don't have to go bigger than a number 3, but use it in your electric motor. Set the speed to 900, 800 RPMs, and just brush against the same wall, the wall that has the same name as the canal you're working in. That would be the safety zone, the zone away from the furcation. And you're going to be doing a safer preparation than using on a slow speed where your speed goes up to 18,000, 20,000 RPMs.
Well, so, while you're talking about all this dentin removal, there's a lot of controversy on how many posts are placed. I mean, so many of these roots are reamed out for a post, and if you have a 2 millimeter ferrule all around the tooth, when do you think you need to remove a lot of dentin for a post?
That's a great question, and I think this would be another 1 hour interview, Howard. But
we'll do it. We'll do it. If you want to come back, yeah.
The question is, sometimes I think we're putting too much posts.
Absolutely.
Sometimes, if I have enough ferrule, why am I placing posts anyways? So molars, where I have 3, 4 millimeters of ferrule, where I have enough tooth structure, why am I putting a post? I could just build a core. Second, the endodontist, when we're doing our obturation and you're doing your 5 millimeter fill or 6 millimeters fill, as soon as you go down there, anyone that's going to put a post should use that room, that space that I have inside the canal to place my post. If I have to put a Gates Glidden there to enlarge, I'm removing too much tooth structure. So it's the anatomy that drives my clinic and not my clinic that drives the anatomy. The anatomy tells me what to do. And I'm not only going to modify the anatomy in a way that I can fit a post there and okay, your post went down there, but you just reduce the longevity of this tooth. So I agree with you. I think the endodontist should do his 5 millimeter fill, and whatever you have there as space is what you should work with. I don't think we should be using Gates Glidden to remove more just so it doesn't make sense. You're removing something in order to restore something. You should be the opposite. You should work with what you have. And if you have enough ferrule, I don't even see a reason why we should be placing posts.
And there's another mindset that every tooth with the root canal needs a crown. And I get it with molars if they had a big 3-surface, big amalgam or whatever. But on those anterior teeth where they have these constricted cervical necks, By the time you prepare this tooth for a crown, you're looking at a grain of rice. I mean, it's ridiculous. They file these teeth down to nothing to restore it with a crown.
I agree with you 100%, Howard. Sometimes I see them removing to build later. Why are you removing? Use what you have there already. So yes, for posterior teeth, full cuspal coverage is important to avoid fracture, and I agree. But anterior teeth, no, we could be doing more, removing less. We could be putting those. Today we have all ceramic crowns. We have beautiful materials coming there. We don't even need the posts. If we have enough tooth structure, build the core and put the crown for sure.
So on these NiTi files, you know, they have a point oh 0.02 taper, 0.04, 0.06. Where do you draw the line? What's too much taper?
That's a great question. Again, the anatomy is going to drive my preparation. So I don't have anything fixed. If I have a tooth, a large tooth that allows me to go up to a 0.6, I will. If the tooth is constricted to start with and I have to stop with an 0.04, I don't mind it at all. So staying between 0.4 and 0.6, that's why I want to draw my line. I don't want to go less than 0.4, and I try not to go more than 0.6. If you look at the new systems that are coming to the market, a lot of them are already reducing their taper. So they're coming with a second version of that file. However, there are some different features in that files, and one of them is, okay, we acknowledge that we have to preserve, let's reduce the taper. So that's becoming a trend, trying to do root canals, preserving more tooth structure. So I know 4 taper is what I usually like to finish, but an 0.6, depending on how big the canal is, I think it's still fine.
And you're very sold on Tulsa Dental Products, Ben Johnson's company's new TRUShape file.
I like those files a lot. Basically, I do my root canals with those TRUShape files. There are cases where I also like to use the Wave 1. And you know what, Howard? It's not about the system. It's about you. If you know your protocol, you're done. And I always, when I present lectures to general dentists, the message that I like to tell them is the difference between an endodontist and a general dentist is how much time we spend with the number 10 and 15 hand file. We spend a lot of time with the 10 and 15. I don't try to do anything if my 15 hand file is loose, it's not loose inside the canal. So those glide path files that they have today is amazing. I think that's the top secret. If you can get one of those file systems all the way there and you have a nice reproducible glide path, give me any system. You can work. The beauty of the TRUShape that I like is that I can do the same as other systems, preserving more tooth structure. So that's the beauty of the TRUShape that I think. I like to preserve tooth structure, and that system really allows me to do that.
Okay, my job is to try to guesstimate the questions that 7,000 individual people are thinking as they're driving to work. And you just said the glide path was so important, and that the difference in an endodontist and a general dentist was how much time they spend with a 10 and 15 file. Were you talking about a hand file?
Hand file.
Okay. Well, will you talk about what is the first file you drop into the tooth, and talk about how you establish your glide path? What are you thinking when you're in a molar trying to establish a glide path before you go pick up a 300 RPM NiTi?
I'm going to tell you what I like to use as a protocol is I don't put any kind of rotary. Doesn't matter if it's a shaping rotary or a glide path rotary inside the canal if I don't have a number 10 hand file loose inside the canal. So my root canal treatment does not start until my number 10 file is actually going in and out 3 millimeters of amplitude loose inside the canal. Then I'm okay. So usually with a lot of lubrication, I like to leave my canals flooded with my sodium hypochlorite. I just, with watch winding motion, I try to go as close to my radiographic length as I can. And I do this in 1, 2, or 3 steps. I don't try to do this at once. And I'm trying to do, we always say that the eyes of the endodontist are on the tip of the finger. So that's what we're trying to do. We're scouting the canals. We're trying to get as much information as we can from the anatomy. Is it constricted? Oh, can I feel that it gets constricted in this area? My file is pre-curved. Do I have a catch in the middle portion? Maybe my canal splits over there. So the more information I can get at this point, it's really going to facilitate my shaping procedure. As soon as my file is really close to my radiographic length, I'm going to irrigate a lot and I'm going to try to determine my working length. As soon as I determine my working length, I have a predictable glide path. Now, another interesting thing to give as a clinical tip is I always keep a number 10 hand file 1 millimeter further than my working length. Because every time I'm working, I always recapitulate with that file, and I'm sure that I'm going beyond my foramen a millimeter in order to leave my foramen unblocked. So that patency file is a file that I use every time I get out with a different file. I go back with that one to be sure that my foramen is unblocked. When my 10 file is completely loose inside the canal, I try to take my 15. This is to create a manual glide path. So I'm going to do the same thing, and I'm going to try to get my 15 all the way to my working length and be sure that my 15 hand file is loose. When my 15 hand file is loose, I have a nice predictable glide path with a 15 hand file. I'm good to start my rotary shaping procedure. If I want to use a rotary system, we have several in the market. Actually, Tulsa has one that I really like called Pro Glider, where you can actually get your glide path with only one eye-tie instrument. So as soon as my Pro Glider gets down there, the tip of the Pro Glider is equivalent to a number 16 hand file, I have my glide path. So I don't know if I made myself understood, but I do not start any rotary treatment procedure or shaping if I don't have my 15 hand file loose or my Pro Glider all the way down there. If you like to use the path files, 3 different files, you want to take at least the path file number 2 all the way down there so you have a nice glide path of a number 15, 16. That's what you want. I spend a lot of time in this procedure, Howard. I spend a lot of time, and I irrigate a lot. So if that's completely loose, my file is loose, and my canal has been previously irrigated a lot, I'm ready to start my shaping procedure.
And how long would you say the average endodontist spends on a molar? Just so these general dentists can kind of put it in perspective.
Depends on the case, depends on the number of canals. If you look at an average, I don't do a molar for less than 5 to 6 units. That would be around 1 hour and 15 minutes, 1 hour and 30 minutes. Because do you know what, Howard? Our shaping procedures today are actually allowing us to shape faster. We can achieve a complete shape of the canal super fast. However, we must understand that we need to leave our irrigant inside the canal. Our irrigant has to do its job. In order for my irrigation to be effective, time that my irrigant stays in contact with the canal walls and with the bacteria is also paramount. So again, if you go back to the literature, you're going to see that you want to irrigate high volumes for a long period of time in order to have an effective irrigant and an effective irrigation protocol.
So the longer that irrigant is in there, the more you're agitating it, the better. And do you think that it helps to agitate that sodium hypochlorite with sonic or ultrasonic?
Both. Doesn't matter. Both sonic and ultrasonic are effective. I like the sonic just because the tip is a plastic tip. And if the canal is curved, I can still go there. The sonic, because the tip is still, it's stiff. I mean, it's an eye-tie or zircon or stainless steel tip. You might not be able to do the curvature, and I don't want to ledge or remove tooth structure. So that's why I like to use a plastic tip. And you said something there that's super interesting. Yes, you must agitate the sodium hypochlorite as well. It's not only the EDTA at the end. I agitate every 2 irrigation. So every time I irrigate twice, my second one, I'm activating for 30 seconds at least.
And when you're irrigating, how far down the canal are you getting your needle to?
That's a great question. We like to go down with a 30 gauge needle, and I try to go close to 2 millimeters shorter of my working length. That's where I want to go. Don't put too much pressure. Don't put pressure on the plunger. We want to keep that needle free inside the canal. We want to go in and out, in and out. We do not want that needle to bind inside the canal in order to avoid any accident with sodium hypochlorite. So yes, there are other systems in the market that allows you to do a passive irrigation. We have the Endovac, for an example. I like just to use my needle, again, in and out. I always put a rubber stop on my needle. So when I put the rubber stop on my needle, I'm sure that I'm not going beyond the limit that I want, and I'm keeping my needle 2 millimeters shorter on my working length.
And what brand of Sonic are you using? What brand? How could someone buy this?
The Sonic I use is the Endo activator from Tulsa. That's
Endo activator?
Yeah.
Okay, I want to switch gears to a lot of dentists wonder if they should do this molar in one appointment or if they should medicate and come back. What are you thinking about when you decide, you know what, I'm not going to obturate this today. I'm going to, why would you do that, and what medication would you put inside the tooth, and how long would you have them wait?
Okay. That's good. With regard to doing root canal treatment in one visit or two visits, we have enough scientific evidence that doesn't influence in the outcome. So what really drives me towards doing one visit or multiple visits, what really differs is, can I dry the canals? First question, can I keep those canals dry? Do I have exudate, pus, blood coming? If I have any of these situations or scenarios, I will not obturate in the same visit. Another scenario that would not allow me to do in one visit is emergencies. If the patient comes to your office with an acute apical abscess, I'm just going to remove him give him some relief, and then I'll work in the next visit. Another aspect that would also drive me towards a multiple visit endo is difficult anatomy. Sometimes we have difficulty dealing with the anatomy, and we actually get tired. There comes a point where your hands are tired. You just can't work the same way. I stop and I book the patient another visit. So those scenarios are what would lead me towards doing an endo in two visits. What do I use? I use calcium hydroxide as my intracanal medicament. And I think that even though nowadays we know that it has a limited antimicrobial effect, it has some, but not as much as we would like that it would have. It is a really good barrier against leakage. So I put calcium hydroxide, and if it's for an antimicrobial activity, I try to leave at least 2 weeks. Otherwise, I just leave it there until my next appointment as a barrier.
And would you call yourself an apical barbarian or a pulp lover? Meaning the apical barbarians, they love to, at the final, they like to see a puff of sealer at the end. And you said you were going a millimeter long to ensure patency. Or are you a pulp lover and you like to just stop, a millimeter from the true apex?
I do not want the puff, but you
don't want the puff.
It's not something that I do intentionally, but I get the puff in 90% of my cases.
So then you're an apical barbarian.
The question I'm going to ask you is, sometimes we know that there are like philosophies that actually are against that puff. However, we all get excited and we're happy when we obturate a lateral canal. I've never seen a lateral canal being obturated without a little puff in the lateral portion. We celebrate, but if I get a puff in the apical portion, I'm going to get sad. It's the same tissue. It's the periodontium. It's just the lateral periodontium and the apical periodontium. What is the difference? So if I allow myself to obturate, and I want that, a lateral canal, knowing that in 99% of the cases I'm going to have a puff there and I'm going to celebrate, what is the problem of having an apical puff if the tissue is the same? I don't think it's going to influence my outcome at all.
When we were talking about failed root canals, you were talking about missed canals. When you talked about that could be corrected with a CBCT, are you when a failed root canal comes into your office and you're wondering why it failed? Are you finding these vertical root fractures with the CBCT or not really?
Not really. Not really. Let me answer you that question with two different topics. First, I do a CBCT scan for all my cases when I'm retreating. When I'm retreating, I do a CBCT scan for all my cases. And the amount of missed canals that we see in the CBCT scan is just huge.
And where are these missed canals? Are they more specifically in a few teeth, or are they every tooth in the head?
I'll tell you, lower premolars, mandibular premolars, we see a lot of missed canals. Sometimes it splits in the middle of the root, and you miss that lingual root or that missed lingual canal. MB2s in second maxillary molars. We know that they're there, and we see them being missed a lot. Lower molars, we see sometimes distal buccal canal missed. So lower incisors, sometimes we see a lingual canal missed. So those are basically what we see. So I like to take the CT, to do a CT scan, and always a limited field of view CT scan in order to address that. And that really guides my access. It guides my access to be conservative. You know him, and I know that he's giving a C course for you. William Nudera has an amazing paper published, and he gives also a talk on selective retreatment. CT scans allows me to do that. It gives me the exact spot where it was missed, where the lesion is, and sometimes I can be more conservative on my retreatment, just addressing the root where the canal was missed. So again, I am preserving tooth structure when I'm doing that. When it comes to vertical root fracture,
because in that case, you wouldn't go back and retreat the obturated canal. You would just go back and retreat the missed canal.
Especially when using a CBCT scan, you can actually precisely determine if there's lesion in the other canals. If there's not, I'm going to discuss with the patient, and I'm going to address only where the issue is, as long as the other canals radiographically seems that everything is okay. With regard to the vertical root fracture, now this is controversial. There's so much artifacts that we can't determine precisely, okay, there's a vertical root fracture here. I'd rather go more with signs and symptoms of deep narrow pocket, J-shaped lesion, sinus tract close to the gingival margin. That gives me more information than the CT scan when it comes to the vertical root fracture. I know that some really rely on the CBCT scan for vertical root fracture. I just think that due to the amount of artifact, I always have that little question mark, is this really a fracture or an artifact? So I rely more on clinical signs and symptoms.
And what do you like more to establish your working length? Do you like CBCT, apex locator, digital radiography, putting a paper point there and seeing goes out the apex and where the red bleeding stops and the white starts the link? What do you like to do for establishing?
Actually, I do a combination. I like to use my apex locator, my electronic apex locator.
What do you use?
I use Root ZX.
Root ZX?
The Root ZX. That's the one I use. I like to do a radiograph. After I use my apex locator, I take a picture. I go there and I take a periapical radiograph, because the Root ZX is going to show me where my length is. But when I take my radiograph, it shows me the anatomy. So now I have my file there, and sometimes I see a little hook or a curvature that I could not see it in the radiograph. So knowing the length is important, but also looking at your file inside the canal and looking the shape that your file has inside the canal gives you a lot of information with regard to the anatomy. My next step is I use my paper points at the end. So my paper points are going to be my last guide in order to determine which is my working length. I also use my Root ZX attached to my rotary files when I'm using my rotary, just to be sure that I'm in the right length as well.
And back to one step or two, your whole thinking on whether you're going to do one appointment or two appointments is really, do you have the time, and can you get it all cleaned out, and can you get it dry?
Yes.
Okay, well, some people say that if there's a periapical radiolucency, that an intracanal medication would be better. Do you agree with that or disagree with that? Or does a periapical radiolucid change your mind on that?
No, it doesn't.
It does not.
No, it's more about, again,
Did they
we
used to
have,
teach that? Did they used to teach that 10 years ago?
oh yes, if
Yeah,
you,
because
you
I
would go to hell if you obturated in one
right.
visit, there was a lesion. But again,
So I just solved one of my own bias. I'm educating myself today because I was always told I always thought Sister Mariella wish she would come after me with a ruler and start spanking my hand with a yardstick if I one stepped something with a periapical radiolucid. But you're saying that's old school, that you don't see evidence.
No, I'm not going to say it's old school. It's a different philosophy. I respect that. If someone comes to me and said, you know what, if there's a radiolucid, I never do it in one visit, I respect, and I think he's doing a heck of a job. Beautiful. But if someone comes to me and said, you know what, lesion doesn't make any difference as long as I can clean everything, I have an apical terminal, I have my patency, and I can still dry the canal, I think he's doing a great job as well. I don't think, and again, we have enough literature today to support that. There is no difference between single and multiple visit with regard to the outcome of endodontic treatment.
Okay, do you ever use antibiotics when you're doing a root canal?
No, I don't. For the specific reason I don't use that is that it's a polymicrobial infection. And when I use antibiotics, it might...
Explain what you mean by polymicrobial.
We don't have only one species of bacteria inside the canal. We have so many bacteria inside the canal, microorganisms, that my antibiotics might work against one species but might not work against the other, and I'm just causing more resistance, and I don't want that. So I think I'd rather use an antimicrobial agent like sodium hypochlorite, or even sometimes adding chlorhexidine, but I would not use an antibiotics for sure.
Do you believe or do you feel that general dentists overprescribe antibiotics during root canal treatments?
Yes, I do.
I mean, I know general dentists that every single patient for 20 years gets a prescription for 10VK or amoxicillin with every root canal.
Yeah, I do too. And that's sad because I rarely prescribe antibiotics. I rarely. If we understand that the cause of the infection or the nature of the infection is inside the root, your antibiotic's not going to reach that area at all. You're giving antibiotics for nothing. You might as well go inside, decrease the bacterial load, and you're giving condition for your body to heal. Antibiotics should only be used if there's any signs and symptoms of the dissemination of the infection. Fever, malaise, lymphadenopathy, cellulitis, I would agree. Otherwise, I do not prescribe antibiotics. And antibiotics, it's only an adjunct. What you do inside the canal is what really makes the difference. So I always like to tell my students that the best antibiotics we have now, Howard, it's called Glidden. So you just get your blade and you just drain that. Allow drainage, and you're going to see how the patient's going to feel much better in 24 hours. You might use antibiotics if you think that the infection has spread. That's fine. Otherwise, draining is sufficient to cause relief to the patient.
And what about pain medication afterwards? Do you regularly always prescribe pain medication after a root canal?
I'm not going to tell you that I prescribe always, but let's say that I really advocate my patients to take, if they can, to take anti-inflammatory drugs for the first 12 hours. So if they could take a couple of ibuprofen after the procedure and 8 hours later another couple of ibuprofen, I think that's more than enough, because that's when we have the peak of the inflammatory process, 12 hours after.
And do again, I know dentists that 100% of their root canals, they will give a prescription for an antibiotic like a penicillin, amoxicillin, and Vicodin, hydrocodone, Percocet. Do you see that too?
No, I see that, but I don't agree. We don't need to go that far. Sometimes just regular Tylenol is more than enough for the first 12, 24 hours, and antibiotics only if needed. I won't prescribe for all the cases. So I see dentists prescribe antibiotics for vital pulp. So the pulp is vital, inflamed, but vital. Why am I giving antibiotics if the nature of the pain is inflammatory?
So
Why am I giving antibiotics for that?
what do you think's a better post-operative, Tylenol, acetaminophen, or Motrin, ibuprofen, non-steroidal anti-inflammatory?
I like the Motrin or the ibuprofen. Yeah, that's what I like. But if the patient can take anti-inflammatory drugs or they're allergic to it or aspirin, I will just use Tylenol.
Okay, and if you did 100 molars, on what percent of them would you use sodium hypochlorite, EDTA, chlorhexidine, or us talk irrigants for a while? I mean, do you always use sodium hypochlorite and EDTA and chlorhexidine gluconate, or what are your thoughts on irrigants? Did I miss an irrigant that you use that I didn't mention?
No. Sodium hypochlorite I use in all the cases. That's my main irrigant. Sodium hypochlorite, that's my main irrigant, full strength, that's what I use. So between 5.25, 6%, that's the concentration of the sodium hypochlorite that I use. Activate my sodium hypochlorite during my whole procedure. When I'm finishing, I'll use EDTA. And I like to have my EDTA inside the canals completely flooded while I'm doing my GP fit. So while I'm doing my GP fit, my canal is flooded with EDTA, and it does its job while I'm doing my GP fit. Now, here comes the difference. I try to separate vital pulp from infected necrotic with or without lesion. If it's a vital pulp, I'll use sodium hypochlorite during 90% of the procedure, EDTA. As soon as I do my GP fit, my final irrigation with sodium hypochlorite, dry the canals, I'm good to go. If I'm working inside a necrotic case with or without lesion, after I use my EDTA, and I'm sure that I irrigated a lot with EDTA to remove my sodium hypochlorite, I'll do my final rinse with chlorhexidine just to enhance my antimicrobial action. And I like chlorhexidine due to its substantivity, its residual effect. So it binds to the dentin, and I like that residual effect. So that's how I separate my protocols.
And I know a dentist personal. She's a great friend of mine. She also says she always uses also hydrogen peroxide, she says, for the anaerobic bacteria. What would you say to her?
I would say use sodium hypochlorite as well. That's the same thing. I don't think that she is doing a bad job using it. No, it looks great. I think she's doing an amazing job. I just want to keep it simple. Otherwise, we go back to that era where we had 300,000 irrigants, and we would spend more time thinking, what am I going to put inside? No. Make it simple. Make it easy. Sodium hypochlorite, EDTA, or sodium hypochlorite and chlorhexidine.
And again, my job is to guess questions if someone's out there, and these podcasts are huge fans in dental schools. I'm worried someone might not know what EDTA is.
Okay, EDTA is a chelant, so it's going to bind to the calcium, and it's great to remove smear layer. So at the end of my cleaning and shaping procedure, we produce a lot of smear layer, those dentin mud that stays attached to the walls, and we want to remove that. So when we use EDTA, I am actually removing that smear layer, and I'm leaving my dentinotubules patent. So the canals, I'm going to have a better, my obturation, my filling is going to be well adapted when I remove that smear layer. That's the only reason why I use EDTA. It has no antimicrobial effect. The only reason why we use EDTA is to remove the smear layer produced during the shaping procedure.
I want to switch gears and talk about something that's kind of controversial and politically incorrect, and we shouldn't talk about. But the reality is this: I see the lawsuits that are settled, and some of these dental malpractice companies send me reviews of what the claims are made. They're still paying claims for the use of Sargenti, paraformaldehyde into, and when I talk to some of these dentists, they still say things that, well, I want an active ingredient in my sealer, and if I use Sargenti with paraformaldehyde, it's going to keep killing bugs, and I've used this stuff for 40 years, and these endodontists are too anal, they don't get it. What would you say to those guys?
Well, I would say two things. One, the time to kill the bugs is during cleaning and shaping. So as soon when you're ready to obturate, you have to be sure that you killed as much as you can. Second, for those that have been using Sargenti paste for 40 years, do you think they would have a different result if they did not use Sargenti paste? That's the question. So the success rate they're having, it's not due to the Sargenti paste, it's due to the good job they're doing with the cleaning and shaping. Sargenti paste is not doing anything. We don't have one relevant piece of literature that shows that Sargenti paste has any effect in mixed with the sealer. So I don't think there's any reason for us to use it. The time to kill the bugs is during the cleaning and shaping. Stay a lot of times there. I stay a long time there. Howard, trust me, I use between 10 to 12 syringes of 10 mLs during my clean and shape procedure. How many general dentists use 10 to 12 syringes during their clean and shaping procedure? Not as much. I know general dentists that uses 1 or 2 syringes during the whole root canal treatment in a molar. That is not enough. So change your protocol, change your disinfection protocol, and you won't have to rely on any antimicrobial property of your sealer. Your filling is there for one reason, to perpetuate the environment that you achieved during your disinfection.
You are very, gosh, I love this. You're just a fantastic communicator, fantastic teacher. You're amazing. I want to switch gears and go to microscopes. When I got out of school in '87, they weighed 1,000,000 pounds and they cost $1,000,000, and they keep getting lighter and smaller and lower cost. When should someone consider getting a microscope? And what brand would you get? How much do you think they cost? And what percent, if you did 100 molars, if you, Rodrigo, did 100 molars, what percent of the time would you pull it out and use it? Or do you have it mounted on your ceiling there all the time? Or?
Okay, well, I started using dental operating microscope in 2000. When I bought the dental operating microscope, Howard, I thought it was the most expensive coat hanger I've ever bought in my life, because the learning curve to it, it's ginormous. It's too much. For you to start learning the microscope, you really have to be engaged and understand that that is a paradigm shift. In my opinion, you should buy a microscope as soon as you leave dental school. Today, you ask me how many cases I use. Today, I use my microscope to do my health questionnaire, just for you to have an idea how much I love my microscope. So there's no way I can survive without it.
And what is the brand, and how many X's that are using? 8, 10, 12?
I use between 5 to 8.
5 to 8?
5 to 8.
And how much? And what brand?
There are two main brands here in Canada, Zeiss and Global. I know there are others. Zeiss, in my opinion, is still the number one. I like the technology. I like
and that's out of Germany, Zeiss?
Yes, and I like the idea of they have amazing features to the microscope. You said something about putting on the ceiling. Great idea. You can have them mounted. The other thing that I would like to tell the general dentist is, if you left dental school now it's a time for you to start working with microscope. The more you wait, the worse it's going to be. Because now you have your routine, you have your posture, you have your ergonomics there. To start from scratch, it's really giving 2 or 3 going backwards. While as soon as you left dental school, you're still learning. It's still a learning process. Starting with the dental operating microscope, it's the best thing to do. We have.
And how much is that microscope, Zeiss? Between
18 to 20,000, you can buy a basic model. You don't have to go to the full BMW, Mercedes. You can start with something simple and add the features as you get used to it. So I don't see any reason. Let me do a quick math with you, and this is what I do with my students when I'm lecturing. If you're doing endo in your office and you have to refer 1 molar a month because that molar you could not do more because you were limited with regard to vision, if now you can do that molar, you're making $900 more. $900 a month, you can lease a microscope easily. So it pays for itself. It's different than the CBCT scan where you're going to have to spend $150,000, $100,000. No, this one, $20,000. If you lease it, you'll pay off easily with the amount of cases that now you're going to do instead of having to refer. Plus, you're going to become more picky with what you're doing. You want to be more diligent to how you're doing endo, and you're going to be doing a better job. For sure, it is a game changer. You're going to be doing a completely different endo when you work under the dental operating microscope due to the magnification and the increased illumination. Both of them together allows you a great vision of where you're working in.
Okay, they understand magnification. You're saying illumination from the light, that the light shining down into the canal?
Yeah, they have a really good light shining down. I don't even use my lights from the operatory. I just use my microscope. If for some reason I want to look with my naked eye, I just put my microscope up, and it's going to be putting its light against the operatory field that I'm looking at.
And between that Zeiss and Global, which one do you personally like more?
That's a good question. If you would tell me that you were going to give one of those as a gift, I would go with Zeiss for sure.
Zeiss. All right. Yeah. And Global, that is it. Where's that out of? St. Louis?
I think we have Global here in Canada. I know that we have in Vancouver. That's where. In the States, I'm sorry, I don't know. I don't know where it's coming from.
And back to CBCT. Some CBCTs, you notice, like orthodontists seem to like this brand more. Endodontists seem to like another brand more. Do endodontists like one brand of CBCTs more since they're doing mostly endo as opposed to orthodontists doing?
I think there are two main brands. With endo, what's super important for me to give as a message to whoever is hearing us is, for endo, we only need the limited field of view. So when you're asking for a CBCT image, ask for a limited field of view. You have a better resolution, less radiation for the patient, and there is less tooth structure or structure for you to do the interpretation. So you're responsible for what you're looking, and you don't want to miss anything. So field of view gives you a 4x4 image, and we don't need anything more than that. The two systems that I use and I work with, the one I prefer more is the J. Morita. J. Morita has a great CBCT scan machine, and there is also CareStream. So both of them allows you a really nice field of view. The resolution is super nice. I like both of them. I still think the image that J. Morita gives me, I like them more than what I get from CareStream. But both of them are good. You would be well served with either or.
And do you remember how much that J. Morita cost, and how much, or the CareStream?
I think J. Morita with a limited field of view, it's close to $100,000. CareStream between 80,000, something like that. I don't know exactly how much it is, but we are pretty close to the $100,000.
And man, that hour flew by so fast. I mean, I loved listening to you. You just quote this stuff like poetry. We covered everything from A to Z. I don't even know if I missed anything. I'm looking over my notes. I can't. Man, I think you hit it all. You are amazing. Hey, I want to tell you, this is a podcasts have exploded because it's a multitasking behavior. Most Americans have an hour commute to work, and these things are on their phone. So they're listening to these as they're driving to or from work, and they're just actually exploded. But we also have online CE. We put up 350 courses, and they've now been viewed over 500,000 times. That's
amazing.
I would give anything if you'd put up an endo course, because when we ask them, what do you want information on? The three things that beat them up the most is root canals, implants, and business practice management overhead. You know, and God, I couldn't think of anything I'd love more than getting a root canal course from you.
Great. Just give me the date and we'll do it.
All right. And if you see Ben Johnson, the founder, you mentioned Dentsply at least 4 or 5 times in this deal, and he's the founder of that, Ben Johnson. So if you ever run into him at an Endo meeting, you tell him that Howard Farran wants to podcast, and that was just an amazing journey. So thank you so much for all that you do for dentistry and endodontics, and congratulations on your outstanding career. And thank you so much for spending an hour with me today.
Thank you, Howard. It was great. Thank you for the opportunity.
All right. Have a great day.
Bye-bye.